Okay. Hey, I'm Brett Blackstock,
I'm Hunter Smith.
and we did our project on pneumothorax. By definition, pneumothorax is the presence of air in the pleural space. It can be defined as spontaneous, occurring from within the lung, medically induced, or traumatic, occurring from trauma to the chest wall. Pneumothorax can lead to ventilatory insufficiency and rapid respiratory decline. Once air enters the pleural space, there's a loss in the negative intrapleural pressure, which results in a collapse of the lung. The negative pressure is what normally allows the lungs to inflate properly. On our assessment, we would find respiratory distress, sharp chest pain, tachypnea, tachycardia. If it's more than 135 beats per minute, tension pneumothorax is likely. Dyspnea, anxiety, diaphoresis, tracheal deviation to the unaffected side, use of accessory muscles, asymmetric lung expansion, absent breath sounds, and hypotension. There's a few different types of pneumothorax. Number one, the most dangerous one is tension pneumothorax. This is when air is allowed to enter the pleural cavity, but it's not allowed to leave. So there's sort of this one-way valve. This allows for pressure to build up inside of the pleural cavity, but it's not allowed to escape. That's the most pressure-induced pneumothorax. Then there's spontaneous pneumothorax, which is just a random occurrence of like a bleb rupturing in your lung. And then there's open pneumothorax, which occurs from like a stabbing or a gunshot wound. And this is when you have that open chest sound, that sucking sound. So the major goals of treatment, we have the immediate goal is to eliminate the intrapleural air and to re-expand the lung, while the long-term goal is to prevent reoccurrence. There's many nursing interventions for pneumothorax, and many of those will be discussed as we get into each of these articles. So for the first article, we have acute pneumothorax. Pneumothorax refers to the abnormal presence of air in the pleural cavity. The air enters from either outside of the pleural cavity or from within the lung itself, as with a spontaneous pneumothorax. The normal negative pressure system we have is lost, and it causes the lung to collapse. The spontaneous pneumothorax affects about 20,000 people in the United States yearly and is the source of about $130 million in healthcare expenses yearly. The major symptoms associated with pneumothorax are sudden chest tightness and pain, and sudden shortness of breath, leading to difficulty breathing. CT scans are the gold standard for identifying pneumothoraces because they shoot a cross-sectional view which highlights the air pockets. There are two primary goals with pneumothorax. One is to get rid of the air in the pleural space, and the other is to prevent the pneumothorax from happening again. The initial treatment of a patient with at least a 2 centimeter size of pneumothorax is a simple needle aspiration. And if successful, the needle aspiration significantly decreases hospital stay times, and there is far less pain associated with that smaller bit. Application for evidence-based practice. Patients on mechanical ventilation have a high likelihood of developing tension pneumothorax, and nurses must diligently assess respiratory status to monitor for the lung collapse. Preventing the reoccurrence of pneumothorax is equally as important in order to prevent readmission and decrease lengths of stay, and nurses must monitor chest tubes and report any suspicions of reoccurrences.
So for the next article, treating pneumothorax, majority of patients present with ipsilateral chest pain and shortness of breath. Shortness of breath is usually heavily dependent on the size of the pneumothorax and history of lung disease. With a large pneumothorax, the patient may have more severe signs such as decreased chest expansion, hyperresonance on percussion, and decreased or absent breath sounds on the affected side. Tension pneumothorax is an emergent and life-threatening situation that should be considered with any patient who has severe respiratory distress. Immediate treatment requires expelling the air from the intrapleural space with thoracentesis. Treatment is aimed at removing excess air from the pleural cavity and preventing any kind of reoccurrence. Treatment for small, non-symptomatic pneumothoraces may only include monitoring with increased symptoms, or monitoring for increased symptoms over time. The patient should be educated to avoid air travel until X-rays can confirm resolution, and you want to administer high-flow oxygen as well. If the severe breathless patients, the air should be immediately aspirated. If they remain symptomatic after the first aspiration, subsequent aspiration or chest tube may be needed. Nurses must have an awareness, regardless of which unit they are on, to recognize and respond quickly to changes that may signal pneumothorax. Based on the article, nurses must also be knowledgeable about pneumothoraces in order to provide education on preventing recurrences and preventing them, period. Nurses must be able to manage patients pre- and post-thoracentesis, such as obtaining frequent vitals, conducting baseline assessments and reassessments, and witnessing informed consent.
And for the third article, it's talking about open pneumothorax and advanced trauma life support recommendations. Based on these recommendations, current management of open pneumothorax entails applying a three-way occlusive sterile bandage over the wound, followed by insertion of a chest tube drainage system. The three-way flutter-style dressing on the wound allows for ventilation and decreases the chances of a tension pneumothorax. This study was carried out in South Africa, and it detailed 58 patients who sustained open pneumothorax injuries, primarily by knife stabbing. 10% of the patients violated the three-way dressing followed by chest tube insertion protocol, and they used a four-way dressing, and then they stitched up the wound prior to medical treatment. These patients had severe respiratory distress, but ultimately they all survived after the chest tube was inserted. There was zero mortality rate with all 58 of these open pneumothorax patients after following these protocols. So for our application, open pneumothorax is a very lethal condition and can leave a person in respiratory distress. These standard protocols of applying a three-sided dressing over the wound followed by insertion of a chest tube is still the best evidence-based practice we have. As nurses, we must continue to apply a three-way dressing over the chest tube insertion site if the tubing becomes dislodged.
And for the fourth article, managing chest tubes are indicated when negative interthoracic pressure is disrupted. Chest tubes help restore that negative pressure that your lungs like to have or that your lungs need, and decreases further respiratory compromise. Chest tubes can pose significant risks such as air leaks or infections or unplanned removals. Air leaks can indicate that negative pressure hasn't been restored and that the injury is not resolving. This can be signaled by continuous bubbling in the water seal chamber. An unplanned removal of the chest tube is an emergency situation as well. When removed from the patient, use a gloved hand to immediately cover the insertion site and call for help. The nurse needs to cover the site with the petroleum gauze and taped on three sides to prevent the air from entering the lungs again. If removal was unwitnessed, cover the site, notify the physician, and obtain chest x-rays immediately and prepare for chest tube insertion. If the tube becomes dislodged from collection device, you want to immediately kink the tubing and place it in some sterile saline or water and obtain a new collection device. And whether it's planned or unplanned removal, the nurse must immediately assess for signs of respiratory compromise with the pulse oximeter, breath sounds, respiratory rate, and their effort. So application, nurses have an important role in managing the actual potential complications from chest tubes, as they are the providers who are closely monitoring these systems and these patients. The nurse must be knowledgeable about thoracic and pulmonary anatomy, as well as the dressing changes, insertion site care, and proper chest tube management. Early intervention for leaks or unplanned removal of chest tubes must be provided by the nurse in order to prevent further respiratory compromise. Frequent assessments of the patient's respiratory status, along with assessment of the tubing and collection system, is necessary to prevent or manage problems before they occur or escalate. So the fifth article compared intercostal tube drainage versus other invasive methods such as aspiration. So the incidence of pneumothorax is estimated about 7.4 to 18 per 100,000 males and 1.2 to 6 per 100,000 females. Recurrence rates after resolution is a major problem. Recurrence rates estimated at between about 23 to 37% after the first attack. The immediate goal of treatment is to eliminate intrapleural air and re-expand the lung, and the long-term goal is obviously to prevent recurrence. There are several methods used for the treatment of pneumothorax, such as chest tube drainage. That's can be considered the standard method used to evacuate air from the intrapleural space, and other studies have shown that aspiration and catheterization connected to a one-way valve are also effective for respanding a collapsed lung, and they had similar recurrence rates as chest tube drainage. The study compared the overall efficiency of intercostal tube drainage or chest tube drainage with that of aspiration and catheterization with the one-way valve. Compared 7 studies that used either aspiration, chest tube drainage, or catheterization as the pneumothorax interventions. Found that aspiration was inferior to chest tube drainage in terms of early success rates, while there was no significant difference in recurrence rates. Aspiration method did result in shorter hospital stays and lower hospitalization rates compared to chest tube drainage, and there were more complications reported with chest tubes. Application to EBP. Appropriate therapy is usually based on many factors, including the patient's overall status, physician's preference, facility's policy, and the possibility of follow-up based on the patient's characteristics. Chest tube drainage is still the main standard intervention for pneumothoraxes. Nurses must be knowledgeable in managing patients with chest tubes and the post-aspiration period. Assess the pulses, respirations, oxygenation, skin color around the site. After aspiration, make sure the patient is positioned on the unaffected side and assess the dressing for unusual drainage. You will monitor the suction control chamber, water seal chamber, and collection chamber for any complications, and provide comfort and psychological support to patients undergoing chest tubes or aspiration. For our last article here, it talks about simulation in nursing education. Simulation provides authentic and clinically relevant opportunities for learning for students. So the patient presented with a dyspnea, tachycardia, and hypotension and was diagnosed with an open pneumothorax. Students were required to conduct interventions such as assessing the patient, giving oxygen, evaluating the pneumothorax, opening the airway, and preparing for drainage with chest tube. Results of the study indicated that students felt more skilled and more prepared after using a lifelike simulation for open pneumothorax. Application, in dealing with complications from pneumothorax, simulation can help improve the critical thinking and problem-solving skills needed to manage open pneumothorax safely and effectively. Providing students with simulation experiences can increase overall confidence and prepare them more adequately for real-life issues. And it's vital that nurses or nursing students be provided with opportunities to engage in these lifelike scenarios so that they can learn and grow from their mistakes without causing any kind of harm.